moderate to severe respiratory distress, all right? All right, so let's go back to our 18-month-old. 18-month-old with mild hypoxia in mild to moderate respiratory distress, all right? Now, let's add that the patient had some wheezing in there, okay? So, if we can take our clinical assessment and, add that, add some more information to it that based, again, on physical exam history or objective data that we have, let's take this, same kid and make him have diffuse, expiratory wheezing, okay? Then we'd have our 18-month-old with mild hypoxia in mild to moderate respiratory distress with, all right, and what we talked earlier on respiratory assessment about what those adventitial sounds help us do, right? And it helps us understand the reason for our change in our clinical status, all right? May or may not lead us directly to a diagnosis, but it helps us pinpoint the problem, where the change in the pathophysiology is happening. So if we throw wheezing in there, now we've got this 18-month-old with mild to moderate distress with obstructive airway disease, right? Okay, that's what wheezing suggests. All right, so now if that's all you tell me, if I'm the medical control physician, okay, and you pick up the, I pick up the phone and you say, Karen, this is Susie Q. I have an 18-month-old with mild hypoxia and mild to moderate respiratory distress with some evidence of, small airway obstruction, by wheezing. What's the next? That's your clinical assessment, okay? We took all that information and in one phrase boiled it down into something that any, medical personnel can understand, and now we know how to approach the patient, okay? What should we do? Mild hypoxia. How do we treat that? What intervention do we perform? Yeah, put him on some oxygen, right? Okay? And then what are we going to do? Okay. All right. The respiratory therapist is hearing coarse, I remember our first assessment was coarse, airway sounds. She's going to want to suction if that's going to be of help in our upper airways, okay? All right? And what else maybe do you want to try if this is the additional one that has the wheezing? Yeah, it's try an albuterol, okay? Because if our assessment is that we are wheezing, okay, and we're not worried about congestive heart failure and we're not worried about a foreign body, okay, our reaction to the wheezing, given the history of URI and everything else, is that this is small bronchiolar smooth muscle problem. So we approach that by giving an albuterol neb, okay? So are those interventions backed up by our clinical assessment statement? Sure. All right, we've got hypoxia. Okay, what's the intervention? Oxygen. Okay, we have, the mild to moderate respiratory distress needs to tell us that, we need to be looking for clues, we need to be trying to help this patient, but, the fact that they're mild to moderate, tells us that, the patient is not in imminent respiratory, is not going to go into imminent respiratory failure, all right? So we have some time. And with the additional clue, auscultation information of wheezing and obstructive airways, that, we try to target that with an albuterol, all right? So your clinical assessment dictates your interventions, all right? What if we have a 7-year-old with a Glasgow Coma scale of 5, all right? meaning that when you look at the patient, he is not protecting, he doesn't have a patent and competent airway. All right? Okay, regardless of your other injuries, which obviously, with more information you would include in this, but certainly your very first clinical assessment is a 7-year-old with impending respiratory failure because of incompetent airway. All right, what's your intervention going to be? Intubation, right? Taking over the airway, making that airway competent and patent. All right, so once again, as always, your clinical assessment determines your interventions. All right, let's say we have a 15-year-old girl. Her heart rate is 150. Okay.